Yes, hello everybody. Today I'm taking this class on physiotherapy management of stiff joints because some students requested to take a class on management of stiff knee, stiff elbow as separately. But I thought it would be best if I covered the basic principles of how a physiotherapist manages stiff joints. And if the principles are same, those could be applied to any joint. So I thought I'll cover those, which would be useful to know for surgeons as well. So moving ahead, let me just first say that, when I say when I'm going to apply my techniques to improve mobilities, when there is reduced mobility or hypermobility, it is termed very varied across textbooks or across regions, from just tightness, soft tissue tightness or muscle tightness to shortness of muscles to contractures, again, a term which is used. And what we think of contractures is an adaptive shortness of soft tissue structures, if it's a muscle, which results from a significant, um, which results in a significant resistance to either active or passive stretch. So if you try to move the joint, you should feel resistance to movement, and that is the contracture. We'll just talk about it as to if it's a muscle related or a non-contractile related tightness, how do we go about dealing with it? So now what happens is anytime a muscle is immobilized, the muscle is not only going to get weaker, that is your muscle atrophy, because that happens when your muscles, which are formed by sarcomeres, we lose those sarcomeres in parallel. Whenever they're added in parallel, there's hypertrophy. When they are lost, you get atrophy. So whenever a muscle is immobilized, sarcomeres are definitely lost in parallel, which causes muscle wasting or atrophy. But whenever a muscle is immobilized in a shortened position, now you would have this dilemma always about, for every fracture, whenever you put a cast, there's a specific position in which you put a cast, or whenever you're going to brace. So which position, which muscles are going to be in the shortened positions or lengthened positions, and how is it going to affect the physiology? So if a muscle is immobilized in a shortened position, sarcomeres are also lost in series. A muscle is nothing but chain of sarcomeres arranged in series, and these bundles arranged in parallel, right? So when it immobilize it in a shortened position, sarcomeres are also lost in series, which means that there is a weakness and there's a shift of the length tension curve. Now, if I don't know if you know about this or not, but muscles are such elastic structures that they produce maximum force in the middle region, because that is where sarcomeres get the most space for overlap. You do not get a very strong contraction when the muscle is in a very shortened position. You don't get a very strong contraction when the muscle is in a lengthened position. So now when sarcomeres, the number of sarcomeres that are there in that muscle, if that reduces, it's going to change your length tension curve, which means that the eccentric capability, the muscle's capability to generate forces while it is lengthening, reduces dramatically. So it gets injured more often. So if a muscle is immobilized in a shortened position, it's weaker, and especially weaker while doing lengthening contractions, because it not only loses its mass, it loses sarcomeres in series also. If a muscle is immobilized in the lengthened position, on the other hand, sarcomeres get added in series. So that is the principle for serial casting or serial bracing. Now you've already lengthened it and you're trying to maintain it in that lengthened position. The physiological changes would be that more sarcomeres get added. Okay, so it causes an increase in the length of the muscle fiber there. So talking about what all reasons could be for stiffness, and as I said earlier, of course, muscle contraction. If muscle is immobilized due to any reason, it could be a chronic reason such as bad posture, or it could be because of a fracture immobilization, or it could be any reason why the muscle would be in a shortened position. It could cause a shortness or contracture of that muscle, the adaptive shortening of that muscle. Stiffness could also be caused because of what we call as a pseudomyostatic contracture, when the muscle is not shortened but it is tight because of spasticity. That also gives resistance to us moving in the opposite direction, but that's not a contracture. We are not able to move the joint through the adequate range also because of joint related reasons or arthrogenic reasons. There could be an osteophyte or cartilage degeneration which could cause it, or they could be fibrotic contractures as well. So there are a lot of structures around the joint which after, let's say, an injury or inflammation, go through some pathological changes, which causes change in the collagen in such a way that there is fibrous changes. Now, it's not just a muscle becoming shorter, there is the connective tissue around that structure is changing pathologically to become more fibrous, which is becoming more resistant to stretch. Sometimes a pathology like adhesive capsulitis, which has these fibrous changes in the soft tissue structures around the shoulder, right? So all of these things could attribute to joint stiffness, and we need to address these differently. Like if it's a muscle tightness, I'll stretch it. If it's any other reason, if it's spasticity, I'll possibly only stretching will not help. I'll reduce spasticity. If it's just a fibrotic contracture, then I'll have to maybe use some other techniques to it as well. So let's discuss what all those are and how do we go about it. So as I said, muscle contracture is decreased sarcomeres, and as fibrotic contractures are nothing but the muscle tissue and the organized connective tissue are replaced by this non-extensible fibrotic adhesions or scar. That is what we call a scar tissue formation, which generally follows an injury or inflammation. So I'm just going to go over these things on a very generic basis. And if anybody has any questions for any specific joints, we'll discuss those as well. Whenever we talk of stretching, we're just moving the muscle in the opposite direction. If a muscle is a flexor, we are doing extension. It could be done by the therapist, which we call as manual stretching. It could be done mechanically with the help of a brace or a splint, or a person can herself or himself attain certain movements or positions because self-stretching. Now, self-stretching is ideal in especially in immediate post-operative conditions. The person gets feedback from doing the movement, and pain associated inhibition will make sure that the person doesn't injure that relatively healing structures, right? So self-stretching is one of the best ways to gain back range of movement after surgery. So definitely teach these things to patients. There are certain techniques that therapists use which are called as neuromuscular facilitation or inhibition techniques. So to relax better after a strong isometric contraction. If a muscle has just contracted, then it will relax better. That is one phenomenon. And the second is, if an agonist is contracting, the antagonist will relax. So we use these two principles to make sure that the muscle is not under any spasm or guarding, so that it allows us to apply force so that I can stretch it. So for example, if I have to stretch my biceps, which has got tight, I'll make the biceps do an isometric contraction, a resisted isometric contraction. An isometric contraction is one where the muscle length is not changing, it's just tightening. So I'll have the person perform a resisted flexion without performing flexion, but just doing a resisted flexion, then asking the person to relax and then moving the elbow into extension. Now, because biceps has had contracted, it'll relax now. Or when I'm stretching the biceps, I'll make the triceps contract against resistance. So when triceps is contracting, my biceps will relax and allow more stretching forces. So these are just certain principles that we use, especially if a person has pain associated guarding, if a person is not allowing me to stretch. So if I ask the person to contract the same muscle which I'm stretching, I get better results. The similar principles is called as a muscle energy technique, MET, or what is also called as a post-isometric inhibition, similar to what I discussed earlier, that a muscle relaxes after performing contraction. The other ways by which therapists increase mobility at a joint are called as joint mobilization techniques. We actually glide or slide the surfaces of the joint. And these glides and slides are based on, so all our joints do not just purely rotate. So if you think of the shoulder joint, let's say, my humerus is not just purely rotating over the glenoid, it also translates in various directions while rotating. That is the reason why it gets movement. And there are certain rules as to which directions do they translate. Like if the convex surface is moving, like especially like the shoulder, let's say, or the hip, when the convex surface is moving, it slides in the opposite direction. Like when I'm abducting, it slides downwards. Whereas if the concave partner is moving, let's say the tibia is moving over a fixed femur, then the translation happens in the same direction.